Like I said, my name is Tanya. I'm a research coordinator at Moffitt. I've been in clinical research for about 8 years now, and kind of going the backward route to medicine. My plan is to, I'm actually applying to medical schools this year and plan to come full circle as a medical oncologist, hopefully in this field, probably for 10 years from now. But when I started interning during undergrad, I realized that I definitely loved research, and I definitely wanted to learn as much as I could before I went full force into the medical profession. And so I started off working at an academic center in pediatrics. I did a little bit of pediatric oncology, mainly I worked in the NICU on GI patients. And I worked there for about 3 years and then transferred over to Moffitt. Worked in phase 1 research for 2 years, where I was doing all solid tumors. And that was where I met Dr. Strasberg and really fell in love with neuroendocrine and transferred over to GI. And now I exclusively work on neuroendocrine, both prospective research, and we do a lot of retrospective projects as well. So Bonnie, if you'd like to introduce yourself.
Sure. Again, Bonnie Bennett. I am a nurse coordinator at the Neuroendocrine Tumor program at the University of Pennsylvania. Our program has been in existence for a little over 10 years. I work with patients with GEP-NETs and also with patients with pheochromocytoma and paraganglioma, and wear a lot of different hats as program coordinator. I organize our tumor board meetings and do all of the documentation in the patient's chart for that, help facilitate patients getting into our program here at Penn. With PheoPara, I'm involved with their blocking plan and seeing them through surgery and then that post-op period as well. How about if the others who have joined us can also introduce themselves and tell us a little bit about what you do at your center.
Hi, I'm Pam Ryan. I'm a neuroendocrine navigator at Ochsner Medical Center in Kenner, Louisiana. Our program's been in existence since 2006, and I had the pleasure and the fortune of working with some neuroendocrine tumor specialists, some oldies, which I absorbed a lot of knowledge from, Dr. Eugene Waltering, Dr. Lowell Anthony, and Dr. Philip Boudreau. And I just fell in love with neuroendocrine, and our program grew over the years. And my roles recently changed over the last couple of years with lots of different restructures and COVID and everything else, as is everybody else's, I'm sure. But currently I focus on inpatient navigation. And it really was an unmet need in our program. And many of our patients, probably over half of them, come from out of state. They come into our hospital, they're with one other loved one, and they really need a lot of hand-holding and guidance to get them through the system and help them through the most vulnerable time of their illness, either a surgery or a liver-directed therapy or a PRRT or something. And I help transition them back home and communicate with their local oncology team. So that's kind of where my focus is now. I do participate in tumor boards and any other projects that come along. But I truly love this patient population. So I do see everything from high grade to low grade to mid-gut lung, just all comers. You never know what's going to come in through our door. And, I really enjoy collaborating with the group at Nanets and many of you on the call today. We've been around for a long time and very, very valuable group. So I appreciate everything. Thank you.
Thank you. That's very interesting that you guys have an inpatient nurse navigator for, I'm understanding, nurse for neuroendocrine specifically, right, Pam?
Yeah, it's something we developed about 2 years ago. And like I said, we identified it. We always knew it was kind of an unmet need. Mm-hmm. And when we restructured the surgeons, our doctors who manage inpatient service, really were like, we need that. Even though we have residents that help run our service, you need some consistency there. And our surgeons typically run our inpatient service and they're always in surgery. So, I help them. I meet them. Ideally, I meet them before surgery. I bring them on a hospital tour, kind of help ease their anxiety level there. I give them a welcome packet, and then, I show them where their loved one's going to be waiting for surgery, and, just go through the ICU, go through the floor, just so they have a better expectation and lower their anxiety the week of surgery. And many of them stay long term and become like our family, and many of them are repeats. And it really is a special bond, and I think it really means a lot to the patients. And when they transition back, a lot of times the plan that was thought of and developed inpatient is lost. So that's kind of the part that I hold on to and make sure it gets translated into the outpatient arena and back to the community oncologist. So it is
Wow.
a new role that not many centers have, but I think it's very, very much needed.
Did you guys model it based on any other program, or you just kind of figured it out as you went with what the neuroendocrine patients needed specifically?
A little bit of both. In my prior life, 15 years ago, I was a transplant coordinator. So we had inpatient transplant coordinators as well as outpatient transplant coordinators. And so we modeled it a little bit after that arena.
Mhm.
A lot of education, a lot of hand holding, a lot of making sure they have their meds, making sure they understand their plan, checking on them post-op day one, discharge
Right,
day one or
right.
two, that whole arena. So really the transplant world, because I was exposed to it,
Mhm.
is kind of what we modeled. But again, we did identify the need, and the needs are, different, as you can tell. But yeah, I think very valued position.
Yeah. Anything specifically that that you would want to see come from the next few meetings at NANETS, or any feedback that you have from previous meetings that you'd like to kind of push forward in the future?
Well, I am on the education committee, planning committee, so I do give input
Yep.
there. And I think we're doing a really good job with hitting lots of different arenas and being really creative with the COVID world and getting things out electronically in different platforms, which is keeping people interested, I think.
Mhm.
So, anyway, we did start before COVID. We started a kind of a nurse group within NANETS to see how we can develop that regionally or nationally. And we kind of got put on a hold because of
Mhm.
COVID. But I think if we pick that back up, Healing Nets was kind of spearheading that. And I think we were making some good traction, and then we stopped. But hopefully we can get that picked back up.
You both have been a part of NANETS for a while, and obviously are leads in the nursing world when it comes to neuroendocrine patients. So I think your roles are invaluable in this setting and in this group, and I'm sure the patients really appreciate what you bring back to them. What have you guys both heard over the years that you think other people have, like, what feedback have you guys gotten from other people that they would want at future meetings? Kind of boost the allied health, engagement and presence really at NANETS.
I think it's really hard to say. It varies depending on your audience,
Mhm.
really. One of the things we were working on was kind of like a toolkit, a nurse toolkit. How do we educate the next generation of nurses for the clinic, for navigation, for infusion, for all arenas? Is there, the floor, the hospital inpatients? How do they take care of neuroendocrine patients? And really like a little electronic and paper form toolkit, because I think, with nurse turnover is always your challenge, and with anybody's challenge really. But additionally, it just kind of depends on what's going on, where you're living and breathing at work, as to if you're going to be able to get away to go to meetings or
Mhm.
participate in different things. So it's always a moving target. But I think we were making some good headway with Healing Nets, and hopefully we can get back to that. What do you think, Bonnie?
Do we have another person on our line? Another participant? Was it Michael?
I don't think so.
Oh,
No, I
there's-
think we lost him.
oh, okay. I was thinking, I've been attending the monthly some of those new sessions that have come up for the monthly programming. And if we could have an allied health session like that, I think that would be great for the nurses to meet, like this kind of format, maybe have something, somebody telling about what they're doing at their program, or, I was thinking about strategizing for how we could grow our allied health membership at Nanette's, and maybe some other ideas like that, try to get some other people interested. I always like hearing from dietitians and, new people that come into the field. They may have some, new ideas, different things that they do at their centers. And it seems to me, Pam, like the centers across the country are really growing. I mean, and all of the, presenters that we have are, great and interesting. And those of us who, attended Nanette's when it was just getting started can just see that growth, and it's really exciting.
Yes, I agree. The other area I see that's growing is the nuclear medicine, obviously. I was on a meeting just last week about, and there was a lot of nuclear medicine presence with the techs as well as nuke med nurses. So that's a whole untapped area of allied health people that can potentially be involved with whatever charge we're gonna bring.
Yeah.
Yeah, the techs are a huge part of the field. And I think, Pam, you were probably on the call when we were talking about coming up with some of the meetings and the speakers, and techs are definitely an untapped source, I think, for these meetings. They really are doing the bulk of the work treating these patients.
Yeah.
And it helps to be able to speak to them and get their experience. I know I personally have, when I started running the clinical trials, especially with the PRRT, and now we have the alpha emitter that's getting started and things like that, just shadowing them to see what their day looks like. It's amazing what goes into just one dose. And I don't think everybody really understands that on the receiving end. Even patients, I don't think, see the full picture of that. So
yeah, I agree. And I think they bring a unique perspective that unlike any of us even thought of.
mm-hmm.
It's a whole different world.
Yeah. I guess we probably need to think of specific topics. I know we want to boost engagement and boost, membership from the allied health groups, but maybe having specific topics, not just generic, let's get the allied health groups together, might bring more people, might get the attention of more people if we can come up with those. I think that way people know exactly what they're walking into and what to bring, what their background is, and kind of target those talks.
I think something that might spark interest in keeping with the nuke med theme is some kind of topic about reaching the nuke med people, saying, learn, understand, or some kind of catchy phrase, but understand the nursing role in the PRT process. And then flip that as well, targeting the nurses, saying, understand the nuke meds tech role in the PRT process. But come up with some kind of catchy saying or phrase, like, wouldn't it be interesting to be a fly on the wall watching or something, because you got to do something like, I want to see what they're doing, idea to kind of capture both audiences.
Yeah. I've heard comments in the past that, when we've had like a separate allied health programming at Nanette's, people said it was hard to choose between the sessions, because the allied health brings a little bit different perspective in than, the straight talks at the sessions. So maybe somehow intertwining them a little bit more might be, an interesting thing to think about trying.
And I completely agree. And I think from what I've noticed at the past few meetings that I've been to, the allied health sessions that have a physician, you know, a lead physician in the group, whether it be like Dr. Coons or Dr. Chan or something like that, that's in that meeting, that tends to boost the number of people that are going to come into that room, at least just from the annual meetings. Yeah.
I see that as well.
So maybe coming up with, you know, I completely agree that we need a bigger allied health presence, but it might be good to have maybe a panel of, or a team that functions very well, physicians plus their, you know, nuke med tech plus their nurse, and kind of talk through what their experiences are, and how all their roles are intertwined. That kind of highlights, I think, that it's a team. It's not just one or two people that are running the departments.
You know, and it was gratifying to participating in some of the programming for Nanette's when Dr. Jimenez commented several times that the talks that were given on, say, theopara or genetics, those kind of things, you know, he found them so helpful. And same thing with the carcinoid heart disease, you know, the physicians that were attending, you know, those sessions saying, you know, how outstanding they were. So, you know, it's good.
What does research look like at both of your institutions? Do you guys have research nurses only doing clinical trials, or do you have coordinators that are focused on neuroendocrine, or is it kind of a basket and you don't really know what you're going to get?
At our center, we had a little bit of both. We had designated nurses. At one point, we had two. You know, at any given time, it's you can have one, you can have three. Who knows? But we try to have designated research staff for neuroendocrine, specifically either a nurse or a couple nurses or a nurse and a tech. So it's kind of a combination and a moving target, but an important spot.
Bonnie, what about you?
We have, I mean, we have a very robust theopara team for our database and tumor acquisition. I know I can send, we offer every patient that comes in the opportunity to participate in that. Most everybody does. So that's a little bit more, I would say, active right now, in that Dr. Metz is on sabbatical and then to retire from the institution. That database had a dedicated person, but they're not so involved in that right now, sort of on hold. But yeah, so I would say we have a little bit of both depending on what area. I mean, Dr. Eads is our lead research NETS designated provider here at Penn, and she's very involved and has coordinators that maybe are GI oncology, so they might do other things, but I'm not, you know, I really don't live in that world. So
Okay.
Yeah, and to add to ours is kind of a little bit more complex than I explained, because we have the LSU side and the Ochsner side. We have the whole tissue acquisition side on the LSU side, which is a whole different group of people doing things, which I'm not too knowledgeable about what goes on nowadays with that group, but that's a whole group managing tissue acquisition and different research trials and having weekly meetings about, you know, different things in the lab. And then we have the other research coordinators I spoke of earlier that are on site doing clinical trials with patients, active clinical trials. And then we have another research component that kind of links the two of those. So it's really complex, but yeah, so always a challenge.
Yeah. So it looks like we had Crystal Flowers just joined. Welcome, Crystal. Would you like to introduce yourself? So I can briefly introduce myself. I'm Tamia. I work at Moffitt Cancer Center in clinical research. We have Bonnie Bennett and Pam Ryan on the call as well.
I think she's maybe, is she from Minute staff or,
I don't think so.
hi,
So we were just talking about the clinical research component at each of our institutions and, you know, what everybody's role really is. It's interesting to hear that there's so many different real setups. Even though we're all technically academic medical centers, you see so much, you know, so much variation in how people run their programs. You know, here at Moffitt, we have, we really don't have any nursing coordinators at all in the GI department. We have some that, I think the breast group has a couple, but really it's primarily non-licensed professionals that are really running the clinical research units. And I'm unique in the sense that I decided to just specialize in neuroendocrine and just stick to that. But most people are kind of like Pam said, just GI coordinators that might touch on neuroendocrine, and it just kind of varies from place to place. So
I don't know if she
hopped off.
so I think they said we have about 10 minutes to go or so. Any other ideas, Pam, maybe about ideas for maybe growing the interest in the organization?
Not right off top. I think this is going to be an interesting year with rebuilding everything.
Mhm.
You know, I think we lost so much in the last year and a half. I think the rebuilding, I think not just with Nanette's, but with everybody's
Yeah.
place of business,
Yeah.
if you will. But yeah, I don't.
I had a couple of things that I thought of. One was maybe to allow each Nanette's member the opportunity to invite one allied health person from the NET community to come to a meeting, you know, without joining, and, you know, hope that they would join, be interested in joining. I know when I very first started, Dr. Metz had said, offered incentive and said, if you participate in a project and work on a poster, we'll help you, you know, get to the Nanette's meeting. But encouraging the members to, you know, include their allied health people in their projects and, you know, maybe offer scholarships in different ways to get, you know, to the meeting. I know that some organizations offer like a test, like some kind of an accreditation kind of opportunity at their national meetings. I don't know if anything like that would be possible, and maybe some collaborative kind of research project that we would work on together, and maybe to unite different centers, like if allied health individuals would be interested in that kind of thing, and maybe a Nanette's, one of the you know, Nanette doctors, fellows, something like that would be interested in leading that kind of a project. Those are just a couple of like ideas that I had.
I really like the collaborative research idea. I think that's a wonderful idea. Actually, I don't know what the project would be, but I'm certainly open. Yeah, that sounds like a fantastic idea. The challenge always is how to get people to meetings. You know, I was in a meeting not long ago about how to get people to join virtual meetings. You know, what kind of incentive can we give patients staff or people. And, it is a struggle. It is a struggle. I often talk to drug reps about the same thing. How do we get people to join a virtual meeting? I mean, everybody's virtual to death. I think this meeting is done very, very well. I'm really impressed.
5 minutes. They're telling me 5 minutes.
Oh, 5 minutes. Yeah, so it's always the challenge.
Yeah, maybe the shorter sessions, like, I mean, I'm interested to see how today goes. Like, I really want to go to the patient meeting too, but, maybe having 2 sessions that were shorter in length, I don't know, so that you're not giving up the whole Saturday or,
I
but
wonder if timing of the meetings too. I mean, I know we're doing a lot of evening sessions for the monthly meetings, but I wonder if doing like a lunch session where you could book a room at your institution and just, bring a bunch of people into one room and kind of live stream. And that way people still feel like they're at a meeting with other people. They're not just sitting at their desk, and it's at a time that is probably convenient for most, but we could always poll and kind of gauge interest once we have topics.
Yeah, I did. I used to be in charge of the in-service of our facility. And one of the things I did, which I thought was pretty successful, was very much that a short session, do 15-minute in-services every Thursday. And we booked the room, we made it mandatory for the staff, and we just live streamed when whoever wanted to come in. Well, at this time it was live people,
Right.
but it was a lot more effective because everybody has to eat, although everybody doesn't eat at the same time or at all sometimes. But, it was a designated time. It was an expectation, and somehow get the buy-ins of the offices, or, get the push from physicians in their area or at their facility to try to push it down to make this some sort of mandatory or have some sort of internal incentives. You can use it for clinical ladder. You can use it for, your evaluation. You can use it for some kind of points or, whatever their in-service incentive type thing is, and use it as little brief in-service type things.
yeah, that's a great idea.
Janice and I were talking yesterday, and the annual meeting this year is going to be in person, but they're also going to have a virtual component, which I really think should boost attendance from especially the allied health team. So I think it's on us to really get the word out. Like Bonnie was saying, if every single person gets at least one other person that's not currently on NANETS's, distribution list or isn't a member, that right there is at minimum probably 100 new people. So
I didn't realize that was going to be the case, that we would have virtual. I agree. I mean, I think, the travel expense is, for allied health is a consideration. And if we have the opportunity to participate, virtually, but I mean, it's always great to see people in person, but still, I think.
Yeah, it's just nice to have it as an option. And with the way that NANETS has done these I mean, last year's meeting was incredible, the annual meeting, and this one is, the same format, and it's the best virtual format I've seen since COVID started.
Yeah. I'm sorry y'all can't see me, but I wasn't prepared to do a video today.
That's okay.
We miss seeing you, Pam.
No.
Well, I would show you, but it's being recorded, so.
We'll save it for the in-person meeting and hopefully get to see everybody this year. I'm looking forward to that.
So we have just 1 minute here. So I don't know, Pam, if you thought this was helpful for your education committee, but I've enjoyed our discussion today.
Yes. It's always great to have good input from, like people, especially if we're targeting a certain audience. We want to, definitely brainstorm together how to get to that audience. And although I'm on the committee meeting, most of them are physicians. So I think it's helpful, a small group.
Yeah. So it looks like we're at time, but really nice to spend some time with you ladies, and hope you enjoy the rest of the meeting.
Thank you.
Thank you.
Thanks. Bye, Pam. Nice to see you.
Bye,
Bye.
Bonnie. Good seeing you
Bye.
too. Bye-bye.
Bye.